type of incontinence and its prevention. So today we'll discuss what are the different types of incontinence, how to prevent them. Instead of management, we'll see the prevention one step back. What are the types and how to prevent it. So urinary incontinence. So what is the urinary incontinence? It's the involuntary loss of urine on any effort. It may be physical exertion, sneezing, coughing, laughing, squatting, even the change of the position. That is bothersome to the patient. That is the most important. The quality of life is affected. That is getting some concern to the patient, and it affects the quality of life. So that is called as urinary incontinence. Okay, so any complaint, in short, involuntary. They don't want to leak it. They want to rush to the bathroom, or while they are coughing, sneezing, and involuntary without the help, the urine is leaking. So prevalence is usually low in young women, and it peaks around the menopausal age, and it rises steadily thereafter into the life. Although the prevalence is low in young women, but in the young women, when there is a milder cases, there is early visit to the hospital. Whereas same in the old age, they think it's a part of a normal aging process. So when the old patient visit you to the hospital for the incontinence, that are usually the severe cases. Prevalence of stress and the mixed incontinence, that is stress and urge incontinence, is higher than the urge incontinence. So in females, usually SUI is more preponderant than in the urge incontinence. So overall, it is 9.7 to 48.4% the incidences between 25 to 64 years of age. So what does IUCA and ICS, International Continence Society, says about the terminology? One is stress urinary incontinence. It starts early in the age in the young female. Urgency, it's usually in the later part of the life, and mix both the stress and the urge. It may either SUI may be predominant, or urgency may be predominant. Okay. So these are basically some symptoms or the type of incontinence what we are saying. One is the SUI, which is the involuntary loss of urine on any activity which raises the intra-abdominal pressure. Again, it's coughing, laughing, sneezing, squatting, change in the position, anything. Urgency, when it's associated with urgency, the patient has the urge to go to the washroom, and there in the time it may leak. It may be wet or dry OAP, what we know as. Postural, this is something new, not actually very new, but the postural, that is involuntary loss of associated with change of body position. Now, in recent last few years only, there has been the study which says that there is a different with the change of posture in the female body, there is the association leakage of the leakage, like gluteus medius, hand grip muscles. Basically, the females who have the relation to the change in the posture, they are more predominant to have incontinence in life. So as we know, as the age increases, the incontinence prevalence increases. So with menopause also the posture changes. We'll see in this something in a different topic detail, the menopause and the change relation of posture and its relation to incontinence. So basically, if a female like walk, there are more change in their posture that leads to change in the incontinence manifesto. The postural urinary, with just in the change of position, or they have this different core muscles is important in the management. Why we are thinking? Because if the posture gets corrected, then the incontinence also can get better. Mixed incontinence, complaint of involuntary loss of urine associated with urgency and also associated with physical exertion. Continuous, that is something true incontinence, that is nothing but VVF, continuous leakage. There is no voluntary going, there is continuous leakage, that is vesicovaginal fistula. Insensible urinary incontinence, that is complaint of urinary incontinence when has the unaware of how it occurred. One thing, the patient is not aware how it occurred because of urgency or SUI, patient is confused. Second, the patient is not aware that she is about to leak. Whenever, as we see in urgency or SUI, the patient knows, yes, now she is going to about cough, or when the urine leak, she will know before only, yes, she is about to leak. Urgency, yes, there is a sensation that if she doesn't rush to the bathroom, the urine will leak. But in case of insensible urinary loss, once the patient is not aware, that is urgency or SUI, and after the urine leak may be activated, then she realizes, oh, the urine has leaked. That is also insensible loss. Now, the various literature what says about the insensible urinary incontinence, there has been, first how to confirm it. History is something very detailed history examination. Second is questionnaire when you have any doubt of whether it's urgency, SUI, warning symptom, pelvic floor prolapse, PFDI 21, distress inventory questionnaire. There are various questionnaires to arrive at a conclusion to find out what is there. And something in this, you require the invasive urodynamic study. Yes, there has been studies which says that insensible urinary incontinence is usually related to urodynamic stress urinary incontinence. So this is something. Coital incontinence, again, why it's new? It's already very old. Like it says that during penetration and orgasm, if it's penetration, some different type of incontinence. When it's during orgasm, it's different type of incontinence. But with the recent literature and evidence, it's like with the coital incontinence is usually the manifestation of SUI, stress urinary incontinence, and when it's manifesting as coital incontinence, then even it's like severe form of it, because it not only affects the quality of life with it, because SUI is there. Apart from that, it will obviously affect the sexual relationship also. So that is something. Then overflow incontinence, which used to be previously the terminology, now it has been replaced with chronic urinary retention. It's also very old, but still in the practice, many of them it has been referred to or over. So what happens in chronic urinary retention? Patient comes with the leakage, and when you evaluate, you come to know the bladder is already filled, and when it's over the capacity, it leaks. That is overflow or the leakage on chronic urinary retention. That's why whenever a patient comes of incontinence, whatever may be the type, it may be a storage symptom or a voiding symptom, you should have basic evaluation of the pre-void and the post-void residual volume. So that will help you in the diagnosis also and in the management also. So type of incontinence, one was the SUI urgency and mixed, what we saw, but again it's divided according to the duration, but it's transient only for some few time of the life. One is the chronic incontinence. Other types, that is SUI urgency mixed incontinence, or the neuropathic neurogenic bladder incontinence, that is nothing but the chronic retention of urine, also can manifest as incontinence. So overflow, chronic retention. So what is the causes of transient urinary incontinence, where for a very short time it occurs? That is delirium, dementia, infection may be of the vagina, cervix, urinary infection, or the chronic constipation may also lead to infection, and it may manifest as incontinence. Atrophic vaginitis, urethritis, postpartum, menopausal, pharmaceutical, some drugs like alpha blockers, the drugs which has a side effect of as a cough, chronic cough, raise intra-abdominal pressure, they may manifest as SUI. Psychiatric causes may manifest as incontinence, whereas to contradict to this, antipsychiatric drugs, they usually have anticholinergic properties in it, and that they usually cure the incontinence. So it's not like antipsychiatric drugs are the treatment for urinary incontinence, but when the psychiatric patient manifests as incontinence, so usually they are on antipsychiatric drugs, they are started, and the incontinence goes away, and when they get good, the antipsychiatric drugs are stopped, again the incontinence recurs. So it need to be evaluated, there may be a different cause for it. Okay. Endocrine causes, yes, diabetes, hypothyroid, obesity, metabolic syndrome, this may lead to incontinence. Restricted mobility, as we said, as the posture or the delay in going to the washroom or holding for many hours, so it's also time. If the mobility is good, then stool impaction, chronic constipation is something very important whenever you see any case of urogyny, so that may lead to incontinence. So stress urinary incontinence, 5 to 69% of women have at least one episode of SUI in their whole lifetime. That's quite huge, and the range also we can see 5 to 70%. About 40% of women with incontinence have SUI. That's why I said the SUI is the something predominant. So in the practice or in the clinical scenario in the society, stress urinary incontinence is more common than the urge incontinence. Okay, annual incidence is 4 to 10%. The very first step in managing mixed signals is to identify the most bothersome symptom by the patient by the proper assessment. So in assessment, whenever you want to manage a case of mixed incontinence, so you will know the type. So whenever a patient comes to you, first you categorize what is the type which the patient is suffering, whether it's SUI, whether it's urgency, whether it's mixed incontinence, chronic urinary retention, neurogenic cause, or the transient, you're ruling out everything. First you categorize. Now what the patient is concerned, patient may be having everything. Patient may be having a neurogenic bladder, she may be having urgency also, voiding difficulty also, SUI also, patient may having everything. Mixed incontinence, any incontinence, basically whenever you have when you have categorized the patient that it is which type of incontinence, Then you'd see which incontinence the patient is most bothered by, and this is by detailed clinical history or the questionnaire and the questionnaire that will help you guide the patient is bothered by which symptom. Okay, or you can directly ask which is the more troublesome, so you focus more on that. So in mixed continent, when it is SUI, this is also where the SUI is basically an anatomic defect that is due to either sphincter dysfunction or abnormal bladder neck support. Again, SUI and urgency, this is the main broader two causes of or types of incontinence. So SUI, you remember, it's something anatomical, and urgency or the overactive way, it may be something functional related to function, pelvic floor. So this is something when you evaluate, you remember, because when there is anatomic defect, it usually requires operative intervention. So whereas urgency, it is functional, which may be idiopathic or due to any neurogenic detrusor underactivity. So overflow, that is nothing but chronic retention which the patient may leak because patient is always bladder full, so it frequently leaks the urine. It may be both due to bladder outlet obstruction or impaired detrusor contractility, or either of it. So what is the reason for it? It may be because of diabetic neuropathy, long standing. Usually when the early phases of life, when the patient is diabetic, you see at patient is having urgency or the SUI, and when the chronic diabetes, patient may have neuropathy, the patient may have chronic retention or the overflow incontinence. That's why, again I repeat, whenever you see a patient of incontinence, whatever you manage, you always do a pre-void and the post-void. Okay, so it can be by ultrasound, it can be by bladder diary, or by just putting a catheter and seeing. So whatever ways you want to evaluate it, you can, but that is something very basic, that any patient of incontinence come to you, you should have this idea what it is. Okay, so what are the causes of chronic urinary retention which leads to incontinence with a full bladder? It's diabetic neuropathy, multiple sclerosis, bladder tumors, prolapse, intervertebral disc, calculi, spinal cord injuries, advanced UV prolapse. The patient both have the voiding difficulty also, and the full is the bladder's PVR is more, and again it leak also. Genital herpes affecting the perineum, as we said, any type of infection may lead to incontinence. So again, now is some of the storage symptom. Storage symptom you can as remember as FUN, that is frequency, urgency and nocturia. So frequency, obviously the patient will have more frequency than the normal. Nocturia, the sleep is interrupted. In nocturia, before the patient goes to bed, that is not counted as nocturial voids. When the patient goes to the bed with the intention of sleeping and get up only for urination and again go back to sleep, that is the nocturnal void, nocturia, and the episodes of nocturia. Okay, sometimes the patient may get up for any other reason and just she's getting up and she may go to the urine, so that may not necessarily be a nocturia. Okay, urgency, the sudden compelling desire to pass urine is urgency. Overactive bladder syndrome, this is urinary urgency accompanied by increase in frequency, and nocturia without leakage, that is, it may be dry OAB or the wet OAB. Dry is dry, there is no leakage. Wet is there is leakage, and it should be in absence of UTI, because if there is UTI, urinary infection, as we saw, there is a transient incontinence, it will cure, so will not label it as overactive bladder or any other obvious pathology like any calculi, bladder tumor. Okay, so that's again the reason for overactive bladder syndrome. So voiding and post-micturition syndromes. So hesitancy, that was the storage symptom, and one is the voiding, when the patient start to void, what problem the patient may have. So when the hesitancy is there, so complain of delay in initiating the micturition. The patient have the full pressure, she has to want to go to urine, she has the full pressure, urgency is there, but the urine stream is not able to. It may be because of bladder outlet obstruction, any sensation impairment, or there may be prolapse, any kinking, that may be the slow stream. As compared to the previous one, the patient may have a slow stream of urine. Intermittency, usually in this cases the patient have the use of abdominal muscle, there is abdominal straining. Again, the patient having the voiding difficulty, she is not able to pass, so she tries to contract the detrusor, give the abdominal straining, the pressure is there, the peak arises, the urine flow starts, then again it stops, and again, so that is something intermittency. Straining to void, again the intensive feta, the abdominal straining also either to initiate, it may be due to initiation of micturition, either to maintain the urine stream or to improve. The stream may be slow. So straining to void, when the patient try to do urination, there may be different reason why she is straining. So if in the history you're asking and you're seeing that patient is straining for urination, then you have to ask whether for initiation she is there, either to maintain, means the without the straining she is not like able to complete for the completing or empty, or the stream, the poor stream is there. So you may need come to able to conclusion of the diagnosis, the management and the severity of the disease. Okay, position dependent micturition. Now in this, the patient adapts from specific position for micturition to occur, for urination to occur, or to improve bladder empty. Now for here, we know that pelvic floor dysfunction is very common, 1 in 3 female have, as I always say. Now there is very bad habit of hovering over the toilet seat for urination. So that damages the pelvic floor. For basically for you females to avoid urination, you need to completely relax the pelvic floor. So when there is the chronic habit of hovering to raise above the toilet seat and void, it may lead to some position. So in particular position only the patient is able to void. That is position dependent micturition. So in that cases, if the patients have leakage in that, patient again have both the component hypertonic or increased tone of pelvic floor and the weak tone hypotonic. And when if there is any complaint, you basically need to rehabilitate the pelvic floor in that. So workup, history, very important. Symptom assessment, what symptom is there, like its urgency, SUI, when it comes, whether she's aware or it's insensible, it's something menopausal related to posture or the position dependent, what are her bladder habits. So this all needs to cover in the history and the symptom assessment. Role of questionnaire, it's very disease specific. There is ICIQ questionnaire is there, urgency, overactive bladder symptom score is there. Then you have pelvic floor distress in with the pelvic or colorectal compartment, prolapse symptoms. They have basically different types of questionnaire for different symptom of this. So you can use any of them. Nocturia, bladder interstitial cystitis questionnaire is there. Incontinence, quality of life, how it is impacting. So whatever, whichever you feel comfortable for the patient, you can use it. So this was in short to how to do the patient evaluation in the basically what are the types of incontinence and how you proceed it further.
Yeah.